Thanks for having me today. So I've come from the rehab engineering unit in Morrison Hospital, and my main role is I work as a specialist seating assessor. So I do complex posture management and wheelchair seating. But as part of my role, I also work for the Pressure Ulcer Prevention and Intervention Service as part of our department. Today I'm going to talk to you about who we are, who PUPIS is. Some of you may have heard of us, some of you may not. And the importance of multidisciplinary team working within that service. And then I'm also going to explain kind of the relationship that's between pressure and posture and why posture management is so important for preventing those pressure ulcers. I'm going to show you some videos that we've developed as a service. So basically the relationship between posture and pressure in both sitting positions and lying positions. I'm going to touch on contractures and sort of have a discussion about is bed always the best place for these patients to be, and then a couple of case studies to finish. So PUPIS, Pressure Ulcer Prevention and Intervention Service. So we're a team of clinical nurse specialists and rehab engineers and healthcare scientists, and we provide a holistic person-specific service that basically looks into the managing and preventing pressure ulcers. And this is with the aim to facilitate timely healing, reduce hospital admissions, and try to prevent those recurring pressure ulcers. So we accept community referrals within Swansea Bay Health Board, and we also honour an existing relationship with Bridgend as well. And the pressure ulcers that we see are the ones that have not responded to local management. So that means ones that haven't been able to heal with nursing input, district nursing input, and basically just need a little bit more advice or input into how to heal those pressure ulcers. So as I said, we're co-working. We go as normally an MDT team. So the specialist nurses have the expertise in complex wounds and can provide advice on the wounds and healing and dressings and strategies to try and improve the healing. But then also we have the rehab engineers, which are specialists in posture and pressure management and have access to specialist equipment. Within our department, we have a workshop, so we have in-house manufacturing facilities to manufacture bespoke custom solutions. So things like foam pads, bed positioning, we can modify armchairs and wheelchairs and all sorts of different things, very custom to the specific application. But it's not just us that can do pressure ulcer prevention. We work with the wider team. We often have, up to 4 or 5 people within our appointments. It's important that we check in with the GP. The family and carers are always quite heavily involved. We work with therapists, so occupational therapists, physiotherapists, the person themselves, the seating team, nurses, basically everyone. It's everyone's responsibility to kind of look into pressure ulcer prevention and management. So moving on to posture. So what is posture? Posture is the position that somebody holds themselves in, so a habitual kind of posture that you naturally adopt, not forcing somebody into a position. It's kind of just the posture that they naturally adopt. So when we think of posture, we have to think of all of 24 hours a day, 24-hour posture management. So what posture in lying, when they're sitting, kneeling, crouching, standing, every scenario, and how much effort is being used within that posture. So you're all sitting in your seats now. How much effort is it taking you to sit in that position? Are you slouching? Are you leaning? Are you comfortable? It's all thinking about your posture, the attitude or position of your body. So there's good postures, there's bad postures, there's a whole range of different postures, obviously based dependent on each individual. So some of you might recognize these people. Quick question for you guys. What do you think about this posture? Do you think these are good postures, bad postures? So quite bad postures. So I think the probably most important thing to say about this is, yes, it looks like they're adopting bad postures, but we all sit like this watching TV in the evening, and we're not saying that every bad posture is necessarily bad. It's just have to consider, is this person going to be like this for 24 hours? Because then we probably are going to say this is bad if you're kind of adopting this position for 24 hours. But if it's a couple of hours while you're watching TV and you're comfortable, then that's okay. These people probably can feel, have sensation, they know if they're in pain. All of you sitting there now, if you start to feel uncomfortable with your legs crossed, you cross your legs the other way, or you move yourselves to get back into a comfortable position. A lot of our patients that we see can't do that. They can't feel pain, they can't move themselves. So it's just important realizing that a bad posture is not necessarily bad, but it can become bad. So posture can have a direct impact on pressure ulcer development. So if you have a poor posture in bed or in a chair, you're then distributing the pressures unevenly. So you can look at some of these graphics. You're getting higher peak pressures on different parts of the pelvis, depending on how you're sitting. So this kind of lean with a bit of a scoliosis, you can see increased pressure to one of your ischial tuberosities rather than the other. And then the same if you're sitting in a sacral sitting position, then your sacrum has a really prominent part and therefore increased pressures. So defining what a good posture is, these are the three kind of main factors of a good posture. So you want to be comfortable, you want to be energy efficient, so not being effortful to hold that posture, and also being able to be functional, so being able to do the activities that you need to do within that position. You need to be able to feel safe and balanced, and also ensure that the pressure is well distributed. So like I said before, posture becomes bad when it causes harm to the body, or if it inhibits the ability to complete those tasks. And then it can also cause further complications. So if adopted for sustained periods of time, so we know that pressure is force over time, then you start to cause stress to those soft tissues. So poor posture can lead to a whole host of different factors. So you've got the muscle shortening and contractures, pain, sleep, function, damage to joints, and you guys can all read. But the main one I've highlighted there is pressure ulcers. So poor posture can lead to those pressure ulcers. So people sitting for long periods of time, they're remaining in one position for a long period of time, perhaps they can't move themselves. So this is when we're looking at poor support and leading to the development of pressure ulcers. These changes can be quite difficult to notice, and once if it happens gradually over a period of time, then it's really, really difficult to kind of reverse those changes that are happening. So it's really important to try and spot when these sort of things are happening. So again, I mentioned before about 24-hour postural management. So we're looking at making sure that you consider every part of their daily routine. So if you've got somebody sitting in a wheelchair and you ensure that their posture's perfect for 8 to 12 hours and then they're going to bed with absolutely no postural support whatsoever, then you're undoing all of the work that you've kind of done. So it requires a multidisciplinary approach. There's obviously like the therapist teams out there, seating assessors, and sleep systems put in place, often useful in combination with people who are in wheelchairs for the majority of the day. Hoisting and positioning is something that we harp on about all the time, about how important it is for getting a good posture for somebody who's being hoisted. So we look at whether the sling is central, too high, head supported, making sure that the person lands in the position that is optimal to them. If it means you have to refit the sling, if it means you have to rehoist or do something to improve that position, then that 5 minutes extra that it takes you, I know none of you have 5 minutes spare in your day-to-day jobs, but if it takes that 5 extra minutes to get them in that right position for the rest of the day, then it's really, really valuable and contributing to that good optimal posture. We often encourage on wheelchairs, if you can use tilting functions to kind of let gravity be your friend and help you achieve those positions. And then also encouraging movement. So for, like I said, for pressure ulcers developing over periods of time, it's actually really significant how much a small movement can impact pressure in a posture. So we often talk about people's room configurations. If somebody's TV is over here and their bed is facing this way, and then they're constantly looking to the left all day, then they're going to start developing poor posture, contractures and pressure ulcers from having to lean to look at the telly because that's what they want to do. So if you're able to just move their bed around or move their TV or raise the TV or whatever needs to be done just to try and ensure that they're not doing something abnormal because of their function, then it's definitely a good thing to do. So this, put a drink slightly further forward so it creates someone to lean forward, relieving the pressure. Side leaned. I think we've had a patient before where the rash tray's been moved slightly further away, so they have to move to flick the rash. So it's just little things like that, giving somebody a hug, taking them off one of their ITs just for a really short period of time, try and create that blood flow and relieve the pressure. So little movements are just as important as big movements. So I'm going to show you the 2 videos that we've developed now. The first one is in sitting. It's about 6 or 7 minutes, and then a video in lying and talking about contractures and posture. So I will leave you to watch them.
Hello and welcome to this short training video on posture and pressure. This is part of a suite of videos from Swansea Bay University Health Board in relation to pressure ulcer care. When considering appropriate seating for those at risk of pressure damage, it is important to consider the 4 S's: size, setup, shape and surface. So it's not just all about what cushion you're sat on. In this session, we'll touch on key principles of seat setup and size, and we'll finish by showing you some top tips for offloading pressure when sitting in a chair. We'll be using a wheelchair to demonstrate, but our principles apply equally to armchairs or other types of sitting. To demonstrate the impact of different body postures on the pressure to the buttocks, we'll be using an interface pressure measurement system or pressure mapping. So this array of sensors allows us to see where the high pressures and low pressures are on the seating surface. So high areas are orange and red, and they represent where there are high forces or weight in small area. The goal for reducing pressure risk is always to distribute body weight as best possible or spread the load, and avoid high pressure areas to the risk areas. These risk areas are nearly always bony prominences. And here we'll be looking at the base of the pelvis, the ischial tuberosities, and the base of the spine, the coccyx, and even the sacrum. Over to Kelly to show us some of the common errors when it comes to seat setup and size.
When someone's chair is too wide for them, they can often be found leaning to one side for support. As you can see on the pressure map by the side of me, all my weight is going through that one side, seeing all those red areas. It can cause my spine to curve over time and lead to postural complications that need to be seen to. Sitting like this also keeps my elbows at risk, as there's bony prominence pressing on a hard surface to try and keep me upright. People often find that their seats are too deep for them, and it means they can't sit all the way back in the chair, like I'm sat now. This leads to the only option to find the backrest. As you can see on the pressure map, all the pressure's going from my buttocks back to my sacrum, which is leaving my pelvis tilted. The sacrum and coccyx are now at higher pressure. I'm also at risk of sliding forward, which is resulting in shear damage at those areas. As well as being a detrimental posture for pressure, it is also not a good position for functioning. This includes eating, breathing and talking. They become much more difficult while sitting in this position. Seats are often too high for people, as I'm demonstrating here. This means that feet don't touch the floor. All the additional weight that normally goes through our feet is now going through the buttocks, as you can see on the pressure mat. This can also lead to feet developing plantar flexion, meaning my feet are pointing towards the floor. Again, similar to the last one, I want to feel grounded, so my feet are going to want to gravitate towards the floor. This will cause me to slide forward in this position so that my feet do end up touching the floor. I'm at risk of shear damage at my coccyx and sacrum. These are also at risk of higher pressure in this position. We often find people sitting with their legs raised. This is either for comfort or because they've been advised to help a condition. Sitting with the legs raised can cause a pull on our hamstrings, leading to pelvic tilt. Again, as before, the pressures are increased to my sacrum and coccyx, as you can see on the pressure mat. This also encourages shearing or sliding down in the chair as you find in a more comfortable position. Also be mindful of the heels. Chairs often have a function called tilt. This is when the whole seat moves together, not just the backrest. As you can see, the chair angle stays the same and the whole chair has come back. Tilt is a really good function, which is you're able to maintain a good posture and it redistributes pressure throughout other areas, for example, the back. As you can see on the pressure mat, all those high peaks of pressure under my buttocks have disappeared. Chairs often have a function called recline. This is when the backrest moves independently of the seat. As you can see, the angle of my chair is opened up. And the inappropriate use of a recline angle can increase pressures to the sacrum, as you can see on the pressure mat. This encourages my pelvis to tilt backwards and I'm at risk of sliding forward in the chair. The best way to offload pressure is to get up and walk around if you're able to. Not everybody's able to, and sometimes they'll have to do small repositioning moves while sat in their chair. These include a small lean forward, and as you can see on the pressure mat, all the pressure's disappeared from my buttocks and coccyx. A small lean to the side takes the pressure off one side, one buttock and onto another. These moves don't have to be drastic. Another one to completely remove the pressure is to lift slightly. You can see I'm not lifting myself up high enough to clear the chair, but the pressure's disappeared.
So be wary of how posture changes over time. Sitting in one position for more than an hour could be unsafe, even if it looks like a comfy seat. Safe sitting is harder for our bodies than it looks. Without appropriate support for our muscles, they have to work hard to maintain position. So seating needs to be appropriate, and we need to recognize the danger of not moving. If it doesn't look like the pressure is well distributed when someone's sitting, have a think about what could help. And for those in our care, it's important not just to think, oh, well, that's just the way they always sit. And do contact a healthcare professional as required. We have other videos and various resources from leaflets, posters, and even a mobile app. Please do get in touch for any other training opportunities.
Okay, so that's video one. Yep, so it's size, shape, surface, and setup. A good quiz for me. No worries. Does anyone have any other questions on the sitting video? We'll go to the lying one.
Hello, and welcome to this short intro into bed positioning and pressure. It's part of a suite of videos from Swansea Bay University Health Board for pressure ulcer care. My name is Kelly, and I'm a rehabilitation engineer working with PUPIS, the Pressure Ulcer Prevention and Intervention Service. And shortly you'll meet my colleague Pearl, a clinical scientist. So why is bed positioning important for somebody? Well, there are a range of reasons to consider this as to why position in bed is important for anybody within our care. Some of these reasons include comfort, pressure relief, to help maintain a good posture, to prevent contractures developing, and to improve circulation and function. It is important to consider the need for good bed positioning for all individuals who have recently come off their feet. They may have reduced mobility or activity, and it will make it impossible or difficult for them to reposition themselves independently. Those deemed at high risk or those who have an existing pressure ulcer also need to be considered for bed positioning. The number of hours that somebody spends in bed can change dramatically. Somebody might have spent 2 hours in bed and this is doubled to 4 hours. This is where good bed positioning techniques need to be considered. When considering bed positioning for those who are at risk of pressure damage or contractures, it is important to consider some basics. Pillows or other bed position aids are a really good support to help keep somebody in their intended position. A good position should keep the spine in alignment and the body in a neutral position, removing any unnecessary pressure from bony areas around the body. The setup of the bed is really important, and correct manual handling techniques. We'll show some examples of good posturing and bad posture in bed and how positioning can have a positive impact.
This person is demonstrating poor posture on their back. You can see that their neck is flexed, so their breathing capacity may be reduced and also the ability to swallow. The arms are curled on her chest, causing the strain to the shoulder muscles and flexion of the wrists. There's no support in her lower back, which may cause strain on the abdominal and back muscles. And the pressure in the sacral area is increased, so it's more at risk of pressure ulcers in this area. There's muscle strain on the knees as they're not supported, and the feet are plantar flexed. This person is demonstrating a good position on their back. They have one pillow under their head and shoulders to prevent neck strain and support the neck in good alignment. There is one pillow beneath the knees to slightly bend the knees and decrease the strain on the lower back, also increasing the contact area over the legs. One pillow is placed between the legs to keep the legs in a neutral position. Be aware of the pressure beneath the heels, and some may also require their arms to be supported. This person is demonstrating sitting up in bed at about 60-degree angle. It's important to be wary of increased pressures to the sacral area in this position. Raising the head of the bed more than 30 degrees increases the shearing forces over the lower back and sacral area, and as the patient begins to slide down towards the foot of the bed, the shear makes the effective pressure worse. Some patients need to sit up in bed at a 45-degree angle, for example such as breathing difficulties or for people who experience heart problems. However, in this situation, it's important that frequent repositioning and monitoring is carried out as they are higher risk for developing pressure ulcers. This person is demonstrating a poor side-lying position. They're lying on one of their arms and the other arm is not supported. There's no support behind their back, no support between their knees, and the high pressure areas to be aware of include the shoulder, the hip, the knees and the ankles, and also should be aware of the ear. This person is demonstrating a good side-lying position. Side-lying can be used on alternative sides. The side-lying position is good for resting and sleeping, but also helps relieve pressure on the sacrum and heels in people who spend a great deal of time sitting and who are confined to bed. One soft pillow is placed under the head and shoulders. It's important to be mindful of pressure on the ear from a hard pillow. There's also one pillow placed lengthways and tucked in at the back, allowing the person to lean back into the pillow, hoping to offload the sacrum and create a 30-degree tilt. There is one pillow placed under the upper arm with the wrist and hand supported, preventing internal rotation of the shoulder. You must also ensure that the lower arm is supported with a pillow. And then there is one pillow between the knees and the ankles. This is an alternative position for side-lying. Where previously the person was rolled slightly backwards, they are now in a more forward tilted position. You may also see that this person has a soft support in their palm. This can help with hand positioning. So what is a contracture? A contracture is a condition of shortening and hardening of the muscles, tendons and other tissues, often leading to deformity and rigidity of joints. This can reduce the range of motion in a joint. It's more difficult to manage someone's pressure risk once they've developed a contracture, therefore we should be looking to prevent and manage these contractures before they develop. People who are deemed at moderate to high risk of contractures are at risk of not only developing pressure ulcers, but also a deterioration in their contractures or spasticity. Examples of this include
people with neurological deficits, for example, multiple sclerosis or stroke or head injury. Also people who have dementia, musculoskeletal problems such as arthritis or fractures, cognitive impairments, joint pain, stiffness on movement, and can also include people who are resistant to accepting care. As mentioned earlier, it's important to prevent contracture development. Preventative positioning in bed is very important. There is a need to support the trunk, the hips, the knees and the ankles of someone who is in need of bed positioning. This will allow them to maintain a good midline position. Some of the poor postures we see in bed include wind sweeping, which is when someone's legs start going to one side, or they start leaning heavily to one side and appear lopsided. Adopting a poor position can result in losing joint range, such as bending of the ankles to walk. Although pillows, cushions, blankets and other soft solutions are generally successful with bed positioning, there are also multiple specialist bed position aids that can assist with positioning someone who may have more complexity, such as a T-roll or W pillows. This is a typical position for somebody who's got contractures. You can see that the legs are wind sweeping to the left, with areas that are left unsupported. Pillows have been put in place to increase the support of the limbs. This will also redistribute the pressure and therefore reduce the risk of pressure ulcer development and further deterioration of contractures. So it's important that we're wary of how posture changes over periods of time. Lying in one position for long periods can be unsafe even if it looks like they're comfortable. It's important to consider good bed positioning techniques when someone becomes off their feet. It's everyone's responsibility to practice good bed positioning for our patients, our family members, and all others in our care. If it doesn't look like the body is well supported or that the pressure is well distributed, then have a think about what you could do to help. Use pillows, blankets, and other soft solutions to assist with bed positioning and to distribute the load for people with contractures. Do contact a healthcare professional for support as required. And if you believe that a person is at risk of developing a contracture, then contact your local therapist team for advice.
Okay, so that's both our videos. So moving on, does anyone have any questions about the video before we move on? No. So moving on, just to talk a little bit more about contractures. Most of it was covered in that video. But what you didn't see was in that video, my colleague Sue, who was the patient, actually found it really difficult to get into a position of a contracture because she isn't contracted. And some of the positions that we see of people who are in bed who are contracted, you couldn't even emulate that kind of posture. We see people's heels who are on literally up against their buttocks or their wrists on their chest, and there's all sorts of positions that have happened over time. So the complex positioning of these contractures makes it really, really difficult to manage pressure. And once pressure damage has occurred, it's really, really difficult to then heal that pressure, which is why we harp on about trying to manage them or trying to prevent them in the first place with 24-hour posture management. So we often talk about whether the contracture is whether it's fixed or flexible. So at the point where this position becomes fixed is when you have what is known as a contracture. But sometimes it gets to the point where these contractures are still flexible and you still have the ability to kind of reduce them from getting worse. So there's people who can get involved in terms of spasticity management, and it's important that physios and sort of the rehab spasticity team get involved at that point to ensure that the correct equipment is in place to try and prevent these contractures. So offloading these areas is the best thing to do. Where that's not possible, then we look to redistribute the pressure. So we're using the soft solutions as mentioned in the video. It's also worth mentioning that there's not a one-fits-all solution, so you might see something on one patient that's similar to another, but actually the way that you manage them is different, and that, I guess, just comes down to experience and seeing all the different cases and doing it on a patient basis. A risk assessment then is often carried out to kind of look at what it's often a compromise of one thing of another based on what your intervention is. And it's also worth looking into why the contracture was developed in the first place, what has changed, what is the history, and can something change, and who else can get involved. And yeah. This is a question we always ask, is bed always better? So as a pressure ulcer sort of intervention service, often we get called and they say, oh yeah, this patient has been put on bed rest. So obviously it's often easier to recommend bed rest for these patients who are complex, but sometimes it's actually not the best place for these patients. If you think about when you're sitting in an upright position, your pelvic bones, so your ischial tuberosities, are more, your sacrum is tucked under and out of the way. So people who have sacral damage actually are causing more damage to their sacrum in a lying, sacral sitting or sacral lying position than they would be sat at a 90-degree sitting position. And the same for lower limbs. You know, if patients are in bed and they've got heel damage, then often when they're sitting out there, the heel damage that's on the backs of their heels is offloaded when they're sitting. So it's often, it's worth looking at if sitting is still safe and not necessarily just making the assumption that a pressure ulcer means this patient now needs to stay in bed until it's healed. And obviously a multidisciplinary team will be the ones to kind of make these decisions, and it's not just a single person decision. So I'm going to move on to a couple of case studies. I have to admit these aren't my case studies, these are historical ones, but I do know a bit of the context of them. So this gentleman, 74 years old, Parkinson, and confined to bed. He had a category 2 pressure ulcer on his left hip, but had quite vulnerable skin and had risk to his knees, ankles and heels as well. There were a lot of people involved in this situation. This patient was in quite a lot of pain and was getting quite contracted. T-roll had previously been provided by physio, but this had been abandoned by carers or family and was no longer being used, which led to a contracture developing. So you can see in the bottom picture there's where I was saying his heel is almost kind of contacting his bottom. So in terms of MDT, they had physio involvement. So the physio was involved in kind of trying to get the joints moving. A consultant rehab medicine was involved to administer Botox, and we were involved then, and also translation was required. So after administering Botox, we got a little bit more movement and managed to get the legs into a better position, so less wind sweeping. As you can see in this picture, we're wind sweeping all the way over to the left, which is really difficult to manage on all of those joints and bony prominences. So the T-roll, which had previously been unsuccessful, was decided it was too hard and bulky and the patient wasn't tolerating it. So they looked at obviously Botox, and then post-Botox looking at bespoke foam supports to kind of emulate the same position as the T-roll, but a much more kind of bespoke and measured. It looks, I mean, like it's just soft padding, but it's done the job and it's got the patient into a better position that was more manageable. I do have to note that obviously here a bit of a compromise has been had with the feet, so we wouldn't normally like the heels and feet to be kind of in that position, but this was a bit of a trade-off for better positioning, less pressure, risk to all of those bony prominences, knees, ankles, and also getting the hips back into a more midline position, but again, they just have to be quite mindful of those feet in that particular position. The second one is a patient with cerebral palsy. Unfortunately, due to the pandemic and all kind of whole host of reasons, this patient just became quite quickly immobile. Actually came off his feet. He was on his feet about 4 years ago. And just due to delay in therapy and different interventions, I think administering of Botox was delayed because of the pandemic. This patient started to develop quite severe lower limb contractures, as you can see. The seating that he had was quite a basic wheelchair, just became completely unsuitable, flat equipment with no contouring and no support, and this led to pressure. So the solution to this was bespoke seating for this patient. We don't always go so quickly down this route, but it felt that sort of this person's mental health and well-being of being able to sit out and function was really important. So custom seated base was provided, and this allowed him to be able to socialise with others, improve function. You can see in the right picture that his foot, the seat board basically became a padded foot plate for him, and he was able to go around for trips around his local village, and his pressure has healed and remained healed. So that was a positive outcome of a bespoke solution. And then finally, this patient had dementia, was quite agitated and had category pressure ulcers to the wrist, which was coming in contact with the chest. This patient also had Botox and physio, but to kind of prevent that pressure further deteriorating and just to try and keep her arms away from her body, these bespoke foam pads were manufactured. This patient had also issues with regulating temperature and moisture. So that's why just standard pillows haven't been used here. They found them too bulky and they couldn't position them correctly. So having this shape and a bit more breathability just seemed to work well for this patient. Obviously, we wouldn't say to always go down the bespoke foam pad route if pillows and other soft solutions were an option, but this was one success story where these bespoke paddings seemed to do the job. And I believe she also healed. So this is just to let you know about an all-Wales guideline for seating and pressure ulcers. This was developed by a big MDT and basically covers the principles of posture, correct seat setup and impact of equipment, similar to what we've gone through today. And this is available on the Postural Mobility Group website, pmguk.co.uk. It's quite a useful resource. So just to summarise, good postural management is essential for function and pressure ulcer prevention. An MDT approach is to both pressure ulcer prevention and contracture management will assist in achieving the best possible outcomes, and it's everybody's role to ensure that early intervention for those who are at risk of contracture development. Thank you.